Good afternoon, guys. This is our next recording or re-recording. Um, Thanks again to Microsoft Windows for mucking up their file types such that recorded videos recorded just 2 years ago no longer work. And so we're doing all these over again. Well, anyway, we probably need to keep it fresh. So this is elbow and humerus. It's going to follow the standard format as we've seen in the hand and the hand, fingers, thumb, and then also the wrist, forearm. We are going to start with a general review of the bony anatomy. We're going to talk about procedural considerations, like artifacts. Now, elbow and humerus, you don't get a lot of jewelry up in that region. There could be some. Yeah, more so you're dealing with like snaps on patient gowns up near the shoulder, if anything, for an artifact. But we'll talk about, should the patient sit or stand? Do we need to shield them? Yes, we do. All those general procedure type things. Radiopaque markers, the whole thing we go through for every exam. General radiation safety practices, protection practices. No reason not to shield the reproductive organs of everybody getting elbow and humerus exams. There's no reason not to. Oh, look, we need a space between the and elbow there. Sorry about that. Proper use of positioning aids. Not a whole lot here. Maybe with the elbow, a 45-degree angle sponge might be of use with your geriatric population, but it more so gets in the way. I think proper use of position aids, more so I want you guys to be aware how to do a trauma elbow, because the elbow, when it's unable to extend, and it's always in a flexed position, which is usually the case when it gets banged up or injured. If the elbow is injured, they really don't want to straighten the elbow. They don't want to move the joint around much, regardless of what the actual injury is, whether it's fractured, sprained, or just tennis elbow overuse, bursitis, all sorts of wonderful things. Nobody wants to straighten a sore elbow. It increases the pain. So we got to find a way to take this radiographic series of the elbow in what's called a trauma series of the elbow with a bent elbow and still get all the diagnostic views. Right? And I'll talk about all of those here in this recorded lecture, but we're going to follow this up immediately with a lab in which I will show you the positioning on one of your fellow classmates or myself, and then we might also shoot the elbow phantom just so we can have a handle on the technique, okay, and get a feel for what a good technique would be for an elbow. So, okay, so starting with our anatomy review, 3 bones involved: the radius, the ulna, and the humerus. This would be the distal end of the humerus for the elbow joint. So the radius is going to be the radius and the humerus. Well, the humerus is more obvious because it's the biggest one. But distinguishing the radius from the ulna is fairly simple. The radius looks like, at the proximal end, the radius looks like the head of a nail, like a carpentry nail. Okay? And so it's got a radial head and radial neck, and that forms like the nail head. And so when you see the nail head, see it looks like the head of a nail, that's always the radius, the other one's always the ulna. Okay? Now your cap, if you're going to wear a cap, it goes on your head. So the capitulum articulates with the radial head, the cap goes on the head. Okay, the radial neck is just a narrowing underneath the head, just like your neck is a narrowing underneath your head. And then there is a bulge for the supinator muscle attachment. The radial tuberosity is actually the focal point for supination and pronation of your forearm. The tendon attaches to the radial tuberosity, and you can see it there at the bottom of the radiograph. It's not pointed out in the illustration, which is weird. Okay, there is a proximal radial ulnar joint, and so the proximal ulna on its medial side has a depression called the radial notch. The radial head fits into the radial notch to form the proximal radial ulnar joint. Your coracoid process is a bird beak-like process anteriorly on the proximal ulna, and the trochlea articulates with the ulna, just like the capitulum articulates with the radial head. Now both the capitulum and the trochlea are the humeral condyles of the distal humerus. They're the condylar surfaces, so it's a rounded process at an articular extremity. Just so happens that the condyles for the humerus are the only ones that have special names. No other condylar surface that I know of has a special name to it like capitulum and trochlea. Okay, they're just called condyles. Otherwise, like the femoral condyles, that's the equivalent of the capitulum and the trochlea at the knee joint, but they don't have individual names. It's just left and right, no, medial and lateral condyle of the distal femur. That's it. It doesn't have like a capitulum name or anything like that. So the only ones with proper names, I would say, would be the capitulum and the trochlea. The cap goes on the head, and the radial head looks like the head of a nail. And so when I tell you the radial head looks like the head of a nail, and the cap goes on the head, you ought to be able to spot, just from knowing those two things, which one's the radius, which one's the ulna, which surface is the capitulum, and which surface is the trochlea. Because you know the capitulum is the articular surface that articulates with the radial head. Cap goes on the head, like we just said. Okay. Going more proximally, there are epicondyles of the humerus. The medial one is more pronounced. It's a little bit larger. Lateral epicondyle is a little bit more subtle, but those are also the palpable landmarks. That and the radial head itself. So basically and your olecranon can be palpated too. So 4 points of the elbow anatomy can be palpated with relative ease. Okay, so the epicondyles, and we actually say 1 centimeter or 1/2 inch distal to the epicondyles is where you'll find the elbow joint. And typically the centering is straight to the inner epicondylar line for this radiograph, for an AP and a lateral radiograph. There's a dark depression there that's actually 2 fossa overlapped. That depression on the anterior side, the smaller fossa, is called the coronoid fossa. And on the posterior side, the larger fossa, which actually makes for that dark circle in the middle of the distal humerus, that's called the olecranon fossa. Your olecranon fossa is basically a depression in the bone in the back of the humerus with a pillow of fat resting in it, so that when you straighten your arm, you don't bang your olecranon against the back of your humerus and make a nice clicking sound or anything like that. It's cushioned, so that fossa has got just a little layer of fat in the bottom of it that makes for a nice pillowy landing for the olecranon every time you straighten your arm. And then, of course, every time you flex your arm up, the bird beak, that is the coronoid process, lands in the coronoid fossa, which is anterior. Now, the coronoid fossa is smaller than the olecranon fossa. And you can see them both better on the lateral. They're superimposed here. Okay. So let's move on to that lateral anatomy. Okay. Again, we can see the radial head. Partially see the radial tuberosity. It's superimposed with the diaphysis of the radius typically. The humerus, right? and you can actually see where it indicates on the X-ray humeral epicondyles. That's actually overlapping the olecranon fossa. And so you can see where the bony cortex kind of pinches in, almost like a medicine dropper releasing a drop. Okay? Um, and I'll show you you can see where it indicates anterior fat pad. That's supposed to show up. The anterior fat pad does sit a little proud of the coronoid fossa, but the posterior fat pad is not supposed to show up. And that's actually a pathology sign that we'll talk about later in the lecture. Now, in profile, part of the radial head is going to be superimposed with the coronoid process, and so we don't get them isolated from each other. Okay, but we can see the radial neck fairly clear and free of superimposition. And we can also see the olecranon process in profile now, down there at the bottom. So coronoid on the anterior side of the ulna, olecranon process on the posterior side of the ulna. And if you are over 6 foot tall, your olecranon processes are probably hooked with calcium deposits like mine are. I'll have to show you. I've got some weapons. It's almost like I have eagle talons embedded into the backside of my elbow. That's how much calcium has deposited on my olecranon process. They look like horns almost. All right, general guidelines. No reason not to shield everybody. The gonads are well away from the area of interest, and so there's no reason. It takes literally 5 seconds to cover those up. And you're also, as I pointed out to Ali in lab last week, you're also covering up the bone marrow for the femur, which is also a radiosensitive tissue. And your femur, the bone marrow is involved in the production of blood cells, your red blood cells, your platelets, your white blood cells, all that stuff, and the plasma is created in the bone marrow. And so it's radiosensitive, and that's one of the ways that you can get leukemia is by having bone marrow that has received too much dose or received dose and it's caused a mutation. Okay? And so shielding for bone marrow is just as important as shielding for reproductive organs. Okay? In fact, all tissue can be damaged by radiation. It's just we focus on the reproductive organs because those can affect unborn offspring in the next generation. Collimate to the appropriate area. Remember what I always like to say, the bones are inside the skin, the circumference of the skin. Unless they're not, and you and the patient and everyone will know when a bone is sticking out of the skin. So otherwise, collimate to just outside the skin surface. You only need 3/4 of an inch outside of the border of the skin. As demonstrated in this picture here, that's pretty good collimation. Okay. Now, what about proximally and distally? How much should you include? You should include about 1/3 of the humerus and 1/3 of the forearm. I think the book says like 3 to 4 inches of collimation beyond the elbow joint, both superiorly and inferiorly. Yeah, that's a good idea. Some doctors want to see half a forearm and half a humerus. Other doctors like center the joint space and give me 2.5, 3 inches superior to the joint space and 2.5, 3 inches inferior to the joint space. Okay. SID is 40 inches for all these projections. We should be able to, even in the case of trauma, should be able to get good screen film contact or good image receptor body part contact and reduce OID, so magnification and blur, shadow edge blur, doesn't become too much of a factor. Patient instruction, hold still. For the humerus, we do want to add suspend respiration because the shoulder can move during the breathing cycle. So, but for the elbow, they can just hold still. Make sure you're marking the correct side with a correct marker. Double check that before you expose. And center the appropriate anatomy to the IR. For the elbow series, it's the elbow joint, and you find the elbow joint by either the bendy part or you palpate for the humeral epicondyles and you center about a centimeter distal to the humeral epicondyles. Our essential projections for the elbow, AP and lateral, and then also both obliques. And then also essential is a modification of the AP for when the patient can't extend their arm. And so for a normal AP, full extension is required. If we can't get full extension and the patient's range of motion is compromised, then we have an accommodation for that, a trauma accommodation, where we split the AP view into a humerus and a forearm bone view with partial flexion of the elbow. And then not really an essential projection, more of a supplemental projection would be the coil method of the elbow. Those will substitute for the AP oblique very nicely. Again, in a trauma setting when the patient cannot straighten their arm, it's kind of difficult to get the obliques to show up. The obliques are good for isolating the radial head and the C between two nations, coronoid processes. But the AP obliques also require full extension of the arm. And so if that's not possible because the patient is injured, we can do the coil method, which is the obliquity becomes the tube angle rather than the body part. And we use a tube angle toward the shoulder to reveal the radial head and a tube angle away from the shoulder to reveal the coronoid process. Okay. Part position for the AP elbow, arm extended, supinated. Okay. They need to try to fully extend and straighten. The shoulder, the elbow, and the wrist should all be in the same plane. We should have good contact with the image receptor, that is body part right up close to the image receptor. And then we want to center to the elbow joint. It says unmasked portion of the IR. We don't really use IR masking anymore. It creates a mistake. And so we just shoot one exposure on one imaging receptor. So how do you localize the elbow joint? Again, you palpate for the epicondyles of the humerus, and it is just distal. The central ray is directed just distal to that. By that I mean ½ inch or about a centimeter distal to the humeral epicondyles. Okay. For our lateral elbow, it's important that we get the shoulder down. The most important part about a true lateral elbow is the shoulder has to be down. The shoulder, the elbow, and the wrist, again, in the same plane, but this time the elbow is flexed 90 degrees. Okay? And so you could say that the shoulder, elbow, and wrist make a triangle in a plane parallel to the image receptor, if you want to think of it that way. So we need 90 degrees of flexion at the elbow, and we need the shoulder down, and that's what's going to open the elbow joint space. Any variation from that and the elbow joint space is going to close off, and it's going to be less than optimal for this radiograph. Okay. Where does the central ray enter? It enters right at the lateral epicondyle of the humerus. So that can be palpated for. It's not as prominent as the medial epicondyle, but you can still find it, and you center to it. Okay. The wrist, forearm, they should be in true lateral. Shoulder should be down so that the armpit is right against the table. Obliques, medial or sometimes called internal rotation oblique. You start out with an AP, arm extended, and then you turn the hand over pronate the hand medially or internally, and then notice that the humeral epicondyles start to roll internally as well. You want the interepicondylar line, that is an imaginary line drawn between the two epicondyles, to be running at a 45-degree angle to the image receptor surface. Okay? The elbow joint hasn't moved just because you rotated the body part. The elbow joint's still where the elbow joint is. And so the same centering applies, about a centimeter distal to the epicondyles. For a lateral rotation, this one actually stretches the ulnar nerve, so be careful and cautious with this one, especially with someone who has possibly a nerve injury or a muscle injury. What you actually have to do for this one is have them externally rotate, but the arm doesn't externally rotate really, really well. And so they actually have to like flex at their waist and their hips and kind of lean their entire upper body over in order to get to a true 45. Okay. For a 45-degree external, we're supinating, but then we're going to keep rolling until the epicondyles are at a 45-degree plane to the image receptor again. Okay. Where do we center? Again, perpendicular to the elbow joint. Rolling the elbow internally and externally does not affect where the joint lies. The joint is basically in the same place. It's just you're rotating the joint to see a different aspect of it with these. Okay. So what will you see? Well, I do have a little bit of image critique at the end of this slide, just to slideshow, just to flesh that out. So I'll talk to you about what you're going to see, what anatomy you're going to see in each projection as you do an elbow series. Okay, so this is external oblique or lateral rotation oblique. Okay, distal humerus, partial flexion. All right, so the humerus, what's the OID for the humerus in this one? Pretty low. We got the humerus against the image receptor, but it looks like a great AP elbow, except what's the problem? The patient hasn't straightened or extended the elbow the whole way because they can't. It hurts. And so what you're going to do is you're going to shoot two different pictures. You're going to shoot an AP elbow for humerus, where the patient's humerus is up against the image receptor, but their forearm bones are kind of floating because they can't straighten the arm. Okay, that's what we see here. We're still directing the central ray perpendicular to the cassette surface. What this does is it partially closes off the elbow and foreshortens the radius and ulna, and the other one will foreshorten the humerus. But as far as the recorded image of the humerus on this one, it's basically the same as for a fully extended arm in an AP elbow. Okay, and so if we did the first one for the bone, the humerus, the distal humerus, we're going to do this second one for the proximal radius and ulna. And so this time the proximal radius and ulna have 0 OID to the image receptor, and the humerus is foreshortened relative to the image receptor because the elbow is bent. We're still centering to the bendy part, or 1 centimeter distal to the epicondyles. Supinate the hand if possible. Okay. Always perpendicular, and then again, always 40 inches. Okay. All right. The worst illustration in the book, ladies and gentlemen, because the cassette has perspective. You see how the cassette is really a trapezoid, but the table doesn't. So the table's a rectangle, not showing you. The rectangular table doesn't really show you depth perception and trying to fool your eye, because what happens with perspective? things that are farther away from you appear smaller. Okay, that's just perspective. Um, as a road wanders off into the distance, it looks like the road gets smaller and smaller and smaller compared to the road that you're standing on. Okay? Well, we have a problem with this illustrator's perspective because the blue area, the image receptor, is a trapezoid indicating 3 dimensions, and that the olecranon is closest to the far end of the table, and that the fingers are closer to the near end of the table. Okay? But the table itself is not a trapezoid. It's a straight rectangle, and so it destroys, and if you look at it too long, it makes your head hurt. How is it that the cassette, it kind of looks like an MC Escher. How is it that the cassette is showing perspective, like 3-dimensional perspective, but the table is not? Is the table even running horizontal? Because now the table looks vertical to me if I keep staring at it. And that's why I say this is a bad illustration. So hopefully we can clear this up with the demonstration of the coil method live in laboratory. I think it's going to be 2 weeks from now. Okay. So what are the key takeaways that I'm going to expect you to know? Central ray angled toward the shoulder at a 45-degree angle, and the elbows flexed 90 degrees. Now, do they have to turn their hand and wrist lateral? No, we're under suspicion that it's trauma, and so we don't want to aggressively manipulate the body part. Okay? They come in guarded posture with their elbow bent, almost like it's in a sling, or possibly in a sling if they happen to have one of those lying around. And we should be able to take all the radiographs without them moving their elbow joint all that much. Okay? So we flex 90 degrees, but the 45-degree transverse angle separates objects in the same transverse plane, so we get separation of the radial head from the ulna and the coracoid process. Okay. Coil method part 2. So remember, these are replacements for obliques. So when you can't get obliques, you have to do the coil method. Coil method number 2 is for coronoid process of the elbow. Okay. Now the coronoid process is on the folded side, on the inside of the flex. Okay. So because it's tucked into the flexed side of the elbow, we need to straighten the arm ever so slightly, about 80 degrees, just to get that coronoid process to show up free of superimposition. Okay. This time we push the anatomy away from the shoulder, which is also away from the head end of the patient. Okay. We push the anatomy. And then we take the radiograph and see. Okay. And again, we got lousy perspective in this picture. Okay. So again, coil method, 90 degrees of flexion aiming toward the shoulder. That's for radial head. 80 degrees of flexion aiming away from the shoulder, or the tube angle goes away from the shoulder. That's for coronoid process. Will those be quiz questions? Yes, they will be. All right, anatomy of the humerus. The humerus is classified as a long bone. It has a head. It's got 2 necks. It's got a natural tapering under the tubercles. And then it's got the beginning of the diaphysis, which is a shaft. And the diaphysis marks the location of the surgical neck. So we have an anatomic neck, above the tubercles, and then we have a surgical neck below the tubercles. And I'll show you where those are on the skeleton from the bin in the back of the room. Okay. The head of the humerus articulates with the scapula. Distal end forms part of the elbow joint. And yes, there's nothing funny about anything I just said. I said there's nothing funny. All right, so here's a close-up picture of the more proximal anatomy. Head and then anatomic neck is immediately after the rounded cap of the head. Greater tubercle and lesser tubercle. Notice the greater tubercle is on the lateral aspect of the humerus, while the lesser tubercle is on the anterior surface of the humerus. Oh, and there's a little valley or crevice in between them. That's called the intertubercle groove, or sometimes known as the biceps groove, because it is where the bicep tendon rests, is in that groove. Going back to the distal humerus, there's the coronoid fossa anteriorly, medial and lateral epicondyle. Radial fossa is, I don't think it's worth mentioning. It is a little divot, but it's not significant. Capitulum and trochlea, remember those are condylar surface. Condylar surfaces, the cap goes on the head. Okay. All right, sorry, I had to come back after a break. Our anterior distal humerus, the humeral condyle. See, I disagree. The humeral condyle is not the epicondyle. That's why we call it the epicondyle. The humeral condyle is the trochlea and the capitulum. The epicondyle, there's a medial and lateral epicondyle, and then the coronoid fossa. So this diagram seems to indicate that the humeral condyle is the medial epicondyle and the trochlea together. I would disagree with that labeling. I would say that the humeral condyle is just the trochlea. Okay. All right. And again, remember the trochlea articulates with the ulna because the cap goes on the head. General guidelines for our procedures. Okay, so we already did all of the elbow, and now we've just got to do an AP and lateral humerus. Shield, collimate to appropriate area. Now, typically you do your humerus exam standing. They could be sitting or they could be lying down as well if they have other injuries. But if it's just a humerus exam, typically we do that one standing. Okay, we do want to collimate to the appropriate area, especially since adipose tissue and breast tissue from the torso could produce excess scatter, which would affect the quality of how the humerus shows up, the recorded detail. And in particular, it erodes the contrast, the natural contrast of the tissue by having a collimated field opened up to include breast tissue on a humerus exam. Okay. SID is 40 inches. Patient instruction, hold still and hold your breath, because the shoulders actually do move ever so slightly as you breathe. And so you can, as you're listening to me right now, close your eyes and put your hand on your opposite side shoulder. Don't have your elbows leaning on the table. Just sit upright in your chair with your arms crossed in front of you. Close your eyes and take some breaths, and notice that your shoulders are oscillating up and down and a little bit back and forth too, a little bit anterior posterior motion too. So plenty of motion in the shoulder during a breathing cycle, so we do need them to hold still and hold their breath to keep those shoulders still We don't get a blurry humeral head. Marking the correct side, left versus right. Center of the anatomy to the IR, mid-shaft of the humerus, halfway between the two bendy parts. Same as we did for the forearm. Okay. We do want to include both joints in the collimated field. And so if you're above the AC joint, you're above the humeral head. As we can see on our model here, that's a very proud clavicle. Okay. But it shows us, we can even see in the silhouette, there's a little bump on the shadow of her shoulder. That is her acromion. And so if the light is extending beyond the acromioclavicular joint, it's definitely captured all the humerus, or all the humeral head, the proximal end of the humerus. 40-inch SID, we're going to rotate to anatomic positions. That means like you're hitching a ride. It's a hitchhiker's pose. Stick your thumb out to the side. They don't have to actually stick their thumb out like they're hitching a ride. They just have to supinate their arm. They can abduct it away from the side of their body, especially if they have excess adipose tissue, to remove skin fold artifacts in the axillary region. And you do want to angle the collimators so that they're running kind of diagonal, because the humerus doesn't run straight up and down. It kind of runs at a diagonal. So roll those collimators about 10 to 15 degrees from straight up and down. See how the rectangle of light is kind of slanted across the image receptor? It's following the long axis of the humerus. It looks like a prettier picture this way. Put your marker outside of the shadow of the patient's arm, and you can palpate for the humeral epicondyles. They should be parallel to the surface of the image receptor, perpendicular to the central ray. Central ray enters halfway between the shoulder and the elbow joints. Okay. Open up the collimation to include the soft tissue border around the shaft of the humerus, and extend the collimation down below the elbow joint by at least an inch, inch and a half if you can. Okay. For a lateral humerus, this is actually not what I recommend. They're doing like an AP version of the lateral humerus. The lateral humerus is actually better positioned in a PA projection. So turn the patient all the way around, have them face the board. They still get into this body position. We just turn them around and then turn their head the other way. And when you do that, the elbow gets right up against the image receptor. Most of your patients, if you do an anterior lateral humerus, anterior to posterior lateral humerus like this, the elbow is going to be floating in space, so it's going to be magnified in OID. Or if you push the elbow against the image receptor to reduce the OID, it is no longer going to be in a true lateral. It's going to be in an oblique plane. And so the fix for both of those is to shoot your lateral humerus from the posterior side, flip the patient all the way around. Okay, that means you spin your collimators the other way as well. Keep the elbow flexed 90 degrees, back of the hand against the hip. Okay, and I'll just have to show you what the PA projection of a lateral humerus looks like. It's actually a little bit easier to do than this one. This one's a little bit awkward and it doesn't give the patient a lot of support, versus I think the patient feels a little bit more comfortable in the PA version of the lateral humerus than the AP version of the lateral humerus. Keep your collimation open to about the same size as it was for the AP. The only thing really you're doing is changing the position of the elbow and the rotation of the humerus. Okay. All right, so a little bit of image critique. We are going to go back and revisit this as a separate, I think, a separate homework assignment. Those start showing up on the syllabus fairly quickly. The guided application worksheets and PowerPoint, separate PowerPoints where the student practices image critique based on a special PowerPoint that I've developed on the various body parts. And so I think I'm going to start sharing those with you soon. This is an AP elbow. The joint space is open. I can see the radial head, um, radial neck, and radial tuberosity slightly superimposed by the shaft of the ulna. That's supposed to happen. Okay, so you're supposed to have slight overlap of the proximal radius and ulna. Okay? The joint space is open. That is between the trochlea, the capitulum, the radial head, and the trochlear notch, which is the gap or the condylar surface of the proximal ulna. Okay, the epicondylar line is running parallel to the image receptor, so draw a line between the medial and lateral epicondyles, and you should see that it's in the same plane as the image receptor. Okay. We can see the bony trabecula, the spongy bone markings at the epiphysis of both the distal humerus and the proximal radius and ulna, the web-like patterns in the bone there. And we can tell the difference between the bicep and the soft tissue around the bicep. And so we got good contrast all the way around. Okay. Here is a perfect lateral elbow. The joint space is open. The only way you get this is if the humerus is in the same plane as the forearm and the humerus is flexed 90 degrees. We can see the anterior fat pad, that little black area right in front of the coronoid fossa. That's normal. Superimposition of the radial head and the coronoid process, the bird beak, or the shark's fin. Sometimes it looks like a shark's fin. Okay, olecranon process and profile posteriorly on the proximal ulna. And you can see the bottom of the olecranon fossa superimposed with the epicondyle of the humerus. Okay. And I can show you all those in, oh, and look, the bony trabeculi and the cortical bone of the diaphysis of the radius and ulna shows up very nicely. Also, the cortical bone diaphysis of the humerus there is also starting to show up. So yeah, where the bone gets really, really thick, yeah, it shows up. Means the radial medullary cavity is nicely demonstrated there. So is the ulnar medullary cavity. All right. The sail sign, you might see that there's a radial head fracture. Well, not just radial head fractures, but, oh, there might be oh no, that's just the border of the radius. At the link at the bottom of this slide, you can find a case study of what is the sail sign. It is a pathology sign, and it's like a little kid's sailboat. Okay, and so what really shows up is the bottom of the sailboat, the fat pad that's supposed to be in the olecranon fossa is displaced. Now we saw just a little of the core of the anterior fat pad, but it wasn't as pronounced like a big giant triangular sail. It was very subtle in the other one. Well, both of these fat pads are being pushed out of the fossa by collection and pooling of hematoma. When you fracture a bone, you start bleeding internally, and the blood has to go somewhere. So it looks for pockets and cavities, spaces between the tendons and the muscles and the connective tissue. And it just so happens that there's like basically two holding tanks, little ponds with fat pads in them, right in the immediate area of the elbow joint. So this is a classic sign. A radiologist would look for the sail sign to show them that the elbow was fractured. Okay, they might not actually, you can see the radial head is fractured here, but even if you can't see the fracture, the lateral elbow can show you occult hematoma by displacement of those fat pads. And they call it the sail sign because the anterior process starts to look like a sail on a sailboat. And if you turn your head sideways, it looks like little George, Georgie from the beginning of the movie It, his little sailboat that he lost in the sewer. Yeah, it kind of looks like Georgie's little sailboat right there. And that's surrounding the fat pads there. So that's why it's called the sail sign. It looks like a little sailboat. And it indicates that the fat pads have been displaced by hematoma. And the only way you get hematoma is there's a fracture somewhere at the elbow joint. So, and you can see the black line right at the radial neck there, peeking out from behind the coronoid process, shows us that there is indeed a fracture. But even without seeing that obvious radial neck fracture, we could tell that this bone was broken because we can see the sail sign. So, all right, this would be our internal oblique, or our medial rotation, or internal rotation oblique of the elbow. This is going to isolate the coronoid process and kind of move every view we get. The coronoid process is either superimposed with the olecranon or partially superimposed by the radial head. Well, in an internal rotation 45 degrees, the coronoid process kind of rolls off of the radial head, and so we can see it free of superimposition. So this is a good view for an avulsion fracture of the coronoid process that can be visualized very clearly. You can also see like an oblique view of the olecranon process, and so if the olecranon is fractured, you might see that one displaced as well on a internal rotational oblique of the elbow. So those are the areas of interest, the coronoid process and the olecranon process. Radial head is non-diagnostic here. You can see it's completely superimposed by the diaphysis of the ulna. So the ulna lies right on top of it. Okay. Our coil method is replacing these oblique views. And so I think I go to the external rotational oblique next, but this is the coil method, and you can see the one on the right. Doesn't that look basically like the internal rotational oblique? It's just the elbow's bent. Yeah, the radial head is tucked behind the diaphysis of the ulna, and the coronoid process is free of superimposition. That's the coil method, 80 degrees of flexion with a 45-degree oblique tube angle directed away from the shoulder and toward the elbow. Okay, not up and down the forearm like the picture might suggest. If you're that picture, the perspective on that picture, oh my God. But the coil method, angling away from the elbow with 80 degrees of flexion, opens up the interior of the folded side of the elbow, the flexed side of the elbow, just enough so that we can see the coronoid process in profile, free of superimposition of the radial head on the right radiograph. So the left radiograph is angling toward the shoulder, and what that does is it throws the radial head and radial tuberosity away from the ulna. And so we get a good isolation look at the proximal radius, the radial head, radial neck, radial tuberosity region. Barely any superimposition at all. And radial head fracture, either avulsion or radial neck fracture. If it's a radial head fracture, you're going to chip off or avulse like the outside corner of the radial head. Or you can get a transverse fracture like we saw in the previous slide of the radial neck. Those are the two common fractures. This coil method, angling toward the shoulder, 45-degree angle with the elbow flexed 90 degrees, is going to isolate the radial head and neck and get it free of superimposition of the other structures. And so that one replaces the external oblique elbow, which is this view right here. This is the external oblique. When we roll the patient into an external oblique, the radius separates itself from the ulna again. All right, so on the previous one, we did that with a tube angle. On this one, we're doing this with body part rotation. So when do you use the coil method? When you can't do body part rotation. So when the arm is injured, we're going to resort, rather than do the oblique series, we're going to do the coil method series. One aiming toward the shoulder for radial head, one aiming away from the shoulder for coronoid process. Okay, but this one external oblique elbow, external rotation, radial head comes free of. You can see the radial notch now on the medial aspect of the ulna as it's articulating with the radial head. So the proximal radial ulnar joint opens up here, and we can also see the radial tuberosity in profile and free of superimposition on this view. AP humerus, this is, oh look, it looks like the labels have been removed, like this could be a quiz question. Well, that would be, the top line would be olecranon, the next line down would be greater trochanter, third line down would be glenoid fossa or glenohumeral joint. Fourth line down, the one that's kind of crooked, that would be lesser tubercle. The one in the middle of the picture, that would be the diaphysis of the humerus. And then we have the medial epicondyle, we have the capitulum, we have the trochlea, we have the ulna or the coronoid process, and then we have the radius is the last indicator all the way at the bottom of the page. But this is an AP humerus. We're in hitchhiker pose. The epicondyles are running parallel to the image receptor, and the greater tubercle can be seen in profile at the proximal end of the humerus. Okay. By contrast, our lateral humerus shows us a lateral elbow view, so we can see the olecranon in profile. Now the epicondyles are running perpendicular to our image receptor. Very much looks the same as the presentation of the lateral elbow down at the distal end. So epicondyles are superimposed, open joint space between the radius and the capitulum, and the trochlea and the trochlear notch of the ulna. There's the shaft. We lose a little bit of penetration power as the shoulder gets thicker up here. We should be able to see the lesser tubercle on the medial aspect, right about where that black line is indicating. That's like right underneath the bulge that is the lesser tubercle. So when you rotate the arm into a lateral position, and that's an internal rotation when you're doing that, that makes the lesser tubercle show up on the medial aspect of the humeral head. Okay. Even though the humeral head is underpenetrated, we got all the humeral head on there, we got the glenoid on there, so the articulation's on there, and we got the articulation at the elbow at the bottom and the epicondyles superimposed at the bottom. So contrast looks good. We can tell the difference between the tricep and the deltoid muscle. There, you guys can see that line, and you can also see the soft tissue is a different color as well. So very good radiograph here as far as brightness and contrast goes. All right, so the proximal radius and ulna are seen free of superimposition in which projection? Proximal radius and ulna. And so there's actually two correct answers to the question. It's the obliques, the 45-degree obliques will do this, but also the coil projections will do that as well. Okay? So, and you do a separate one. If you roll the patient externally, you're going to get the radial head free of superimposition. If you roll the patient internally, you're going to get the coronoid process free of superimposition. Demonstration of the posterior fat pad on the lateral projection of the adult elbow can be caused by, it is both trauma or other pathology, but also less than 90 degrees of flexion. And so if they have their arm extended ever so slightly and not truly 90 degrees flexed for that lateral, that can cause relaxation at the triceps tendon on the posterior side of the elbow, and it could cause that fat pad, the olecranon fat pad, to expand and give you a false positive for the sale sign. Okay? And so the sail sign's only accurate if the elbow is actually 90 degrees of flexion. If they can't flex their arm 90 degrees and you see a sail sign, it's not necessarily indication that the arm is broken. It's got to be at 90 degrees of flexion. All right, we made it to the end of another one. Ooh, coming in right at an hour. That's fantastic. So we talked about the anatomy of the elbow and humerus. That will definitely be on an upcoming quiz. General procedure considerations. Remember, for the humerus, we do have to start invoking breathing instructions. Hold your breath for your humerus exams because the shoulders do oscillate during the breathing cycle. No reason not to shield everybody. The elbow and the humerus are well away from reproductive organs, and the reproductive organs and the bone marrow in the torso can benefit from radiation shielding. And so we use lead aprons for all our patients getting elbow and humerus exams. Okay. Proper use of positioning aids. I did mention that. I can invoke those in lab demonstration. Sometimes your geriatric, in particular, it's the oblique positions. The geriatric patients can't hold those positions real well. So either sandbags or sponges or a combination of both can be helpful with. Just be careful using the sandbags with the older folks. So, and with the traumas, avoid the sand because the sandbag does provide a weight, and it could lead to a false extension or a forced extension or forced manipulation. Pinning down the arm with a sandbag might exacerbate an injury in a trauma setting. So watch the use of the sandbags as a immobilization device during trauma because you might be manipulating the joint with that weight. So simulations of the exam of the elbow and humerus, that is coming in positioning lab probably the Monday after Thanksgiving, I think. I'm not sure. Check your syllabus schedule to be sure. I'll see you guys later. Take care.